Welcome to this webinar series, which features the 2020 standards for the Commission on Cancer Accreditation Program, which is called Optimal Resources for Cancer Care. In this webinar series, we'll review all of the standards for our 2020 standards, and this first series involves the standards 1 and 2. Remember, these standards are effective January 1, 2020. We're going to look at all of the accreditation standards. They address changes to our accreditation process. New terms are defined in our glossary, and there are specifications by category. Next slide, please. Remember, you can access the 2020 standards and resources directly from our web page, which is displayed on the screen. Next slide. The first standard deals with institutional administrative commitment, which is a very important concept for any accreditation process. Next. The institutional commitment is absolutely essential for the development and success of an accredited Commission on Cancer program. There are many things involved in this process, and as you see from the slide, there's resource allocation, which is important, as well as equipment, personnel, and administrative support. We need to always focus on patient safety and continuous quality improvement. Next slide. This involves a commitment by the administration to offer a letter of authority from the facility leadership, which is generally the CEO or the equivalent. This demonstrates the commitment of the Cancer Committee, which includes, but certainly is not limited to, other members that you see on this slide. Now remember, the CEO or another member of the C-suite must be the one who develops this particular letter for the facility. Next slide. When should the letter be written? Well, once each accreditation cycle, the cancer program must fulfill the compliance criteria. If new programs are developed at different times during the 3-year accreditation cycle, of course, the letter can always be updated. Next. Remember, all of these must be included in the pre-review questionnaire, or the PRQ, which has replaced the SAR. This includes the letter of authority and includes all the required elements, as well as descriptions and information that are included in this particular program and its category. The next slide introduces us into the program scope and governance. This is a very important standard, and throughout Standard 2, we will talk about all of these areas that are important for our standards. The first is the rationale. The cancer program and its medical staff provides the structure, process, and the personnel to obtain and maintain the Commission on Cancer's standards. All of these areas are important because they demonstrate a commitment to the broad cooperation throughout the facility being accredited. Next slide. As has been true in the past, Standard 2.1 covers our Cancer Committee. The care of patients with cancer requires a multidisciplinary approach and encompasses physician and non-physician professionals. This slide goes over who are the committee members, and remember, at least one physician representing each of the diagnostic categories is extremely important. Also, the coordinators, the administrators, the clinical care coordinators, and supportive services are always represented by the Cancer Committee. Next. The required members are very important and must always be listed for every Cancer Committee meeting. These consist of the Cancer Committee chair, your cancer liaison physician, a diagnostic radiologist, a pathologist, a surgeon, a medical oncologist, and radiation oncologist. Now, of course, there may be other physician members who are on the cancer committee, but these are the major components. The required non-physician members would include the cancer program administrator, the oncology nurse, the social worker, and of course, the certified tumor registrar. There are several coordinators that are required to be on your cancer committee. These are programmatic leaders and represent the cancer conference, the quality improvement area of your institution, the cancer registry, the clinical research, the psychosocial services coordinator, and the survivorship coordinator. Now, many of these roles could be overlapping, but in any functioning cancer committee, these members have to be listed. Next. So what is the role of the certified tumor registrar? Well, the certified tumor registrar could be a coordinator for two specific areas. One, of course, could be the cancer conference. The other could be the cancer registry quality coordinator. And certainly it is recommended that in some larger institutions that these two could be split up, but the certified tumor registrar or CTR could cover both of these areas. Next. Now, under the cancer committee, many members are recommended but may not be required. And as I mentioned before, there may be specialty areas represented in the institution that physicians could be on the cancer committee but not required. Palliative care is a very important area which should be represented on the cancer committee. The genetic counselor could be represented also, and any physician who qualifies as a geneticist. The registered dietitian is an important member of the cancer committee, as is the rehab services professional. The pharmacist is represented, as is pastoral care, and of course, we always want to have the American Cancer Society represented, although this is not required. Next. Now, remember that the pre-review questionnaire has to document all of the activities of the cancer committee. So the person taking care of the minutes of the cancer committee is a very important member of the institution and the cancer committee. They should identify clearly all the cancer committee members, both required and non-required members who attend meetings of the cancer committee. Next. The cancer liaison physician is an extremely important member of the cancer committee and represents many different areas. This slide shows that the CLP certainly must attend the survey, is an alternate for the chair if the chair can't run the cancer committee meeting, may serve as the quality leader because the cancer liaison physician must report certain benchmarks throughout the year, is a quality champion, and certainly looks at overall performance of the institution relative to the NCDB data and other data that's sent in for the institution to review. So again, the cancer liaison physician is an extremely important individual, and this has not changed in the 2020 standards. Next. In the pre-review questionnaire, the cancer committee minutes must always document the CLP report and any activity that the CLP feels is important for his or her specific job description. Next. Now, as far as meetings go for the cancer committee, remember that the committee must meet at least once each calendar quarter. So this slide reflects the various quarters of the particular year that the committee is in function. Now, it's always important that the cancer committee meeting should be set up early in the quarter, especially if there's any opportunity to miss meetings, because it's very important to have a meeting every quarter. and 4 meetings are required for the year. What are the committee's responsibilities? Well, to schedule and reschedule meetings, to document all activity that occurs in the minutes, and to also establish any subcommittees that are important for programmatic activities or work groups that are recommended throughout the year. All of these activities should be reflected in the minutes of the Cancer Committee. Next. There are examples of optional subcommittees, and these tend to work quite well, especially in institutions which are larger and more complex. These may be related to the clinical and translational research activities, or for screening and prevention. Quality control certainly is a separate area that may require a work group to carry on the important activities of quality initiation. Quality management and improvement, and of course, review of all policies and procedures is an important aspect of all of the Cancer Committee work, but could be covered in an optional subcommittee if needed. Next. As far as Cancer Committee attendance, this is covered in Standard 2.4. It is exceptionally important that members, especially the required members of the Cancer Committee, attend all meetings throughout the year. Now, the benchmark for attendance has been set at 75%. So each member of the Cancer Committee, each official member, must attend at least 3 out of the 4 meetings of the Cancer Committee each year. If members don't attend on a regular basis, then effective work cannot be handled by the committee, and this is the reason for this attendance status. Now, to whom does this apply? Again, it applies to the required physicians and all health professionals that are required by the Cancer Committee, including the coordinators. Attendance has to be monitored very carefully by those taking part in the minutes. So again, for the PRQ, attendance has to be reported. Next. Now, there are, again, important points about attendance, and that covers the alternate situation. There could be one designated alternate for each required member. We've already stated that the CLP can be and is the alternate for the chair of the committee. Now, the alternate must be qualified and credentialed for that particular role, such as if a medical oncologist cannot be at the meeting, another qualified medical oncologist should be sitting in at his or her place. An individual can only serve as an alternate for one other individual. Now, alternates must be identified at the first meeting of the calendar year, and this has to be reflected in the minutes. Alternates, of course, can change, but again, this has to be reflected very clearly. If somebody moves out of town or leaves the facility, a new alternate can be selected for this particular accreditation cycle. Now, members should attend in person, but there is an opportunity to use teleconferencing or video conferencing for meetings. But again, to have this in effect, the individual attending by teleconference has to have all of the appropriate meeting documents given to him or her prior to the meeting. Next. Again, for the pre-review questionnaire, the minutes are extremely important. So the required member attendance for each Cancer Committee meeting has to be reflected very carefully in the minutes. And if an alternate attended for a required member, this also has to be reflected in the minutes of the Cancer Committee. Next. Standard 2.5 is extremely important and covers the multidisciplinary cancer case conference. This is really the benchmark of any accrediting institution. There has to be multidisciplinary team involvement, and this has to be carefully monitored on the minutes of the cancer case conference. Clinical decision-making, outcomes, and patient experience are reflected in any cancer conference held at the institution. So who should keep the Cancer Committee informed about the conference activity? Well, this certainly should be the Cancer Conference Coordinator. The coordinator should monitor, evaluate, and report on all of the important activities that take place in a cancer conference. Next. Well, how do we manage an effective cancer conference? There should be policy and procedures, which the entire Cancer Committee must review on an annual basis. These are bulleted here on this slide. There should be multidisciplinary participation. There should be a frequency and a format established for every conference that's held at the institution. There should be various elements of discussion that are mandatory for any effective conference. These involve clinical or pathologic staging of every case that's presented, treatment planning for any patient presented, and use of evidence-based guidelines such as the NCCN guidelines. Genetic testing should be discussed where applicable for every patient discussed at a conference. Clinical research studies should always be brought up for discussion if the patient warrants such a study. And of course, supportive care services such as palliative services and other supportive care should be mentioned for every patient affected by these areas. The number of cases presented and the percentage of prospective cases presented should always be reported by the conference coordinator. And of course, methods to address areas that fall below the levels should always be stated in any cancer conference policy. Next. How do we look at the schedules of these conferences? Well, we have to look at the general cancer case conference. Now, it's not required necessarily to have a general conference at every institution, especially at very complex institutions, which may have multiple conferences that are geared to multiple sites of illness. These are specialty or site-specific conferences. Certainly having a general cancer case conference covers important issues that may not be covered in site-specific conferences. So these are areas that the cancer coordinator must be responsible for. Now, programs can either hold a general multidisciplinary case conference or specialty case conferences, but remember the benchmarks of a cancer conference have to be listed no matter if it's general or specialty involved. Now, if you have a specialty case conference, the individual physicians that are important for that particular illness must be present. So that's a very important concept to always think about. Next, when we hold a cancer conference, remember that 15% of your annual analytic caseload must be presented at the conference. So it's important to keep these numbers, and this is a very important job of the cancer conference coordinator. Also, 80% of these patients must be presented in a prospective fashion to indicate these are active patients being considered for active therapy. Now, which cases are prospective? Well, certainly cases that are newly diagnosed and you haven't yet decided on your treatment paradigm, and you have discussion of additional treatment if a patient has been presented previously. They could be previously diagnosed patients, but the initial treatment has been completed, the patient has had recurrent disease, and new discussion needs to take place regarding surgical management or other management, such as medical oncology management or radiation. Or the patient could have been previously diagnosed and discussed, but now new supportive areas or new palliative care issues need to be discussed. And these are very important for discussion of our prospective cases. Next. Again, for the multidisciplinary cancer conference, you have to think very clearly on who should be present. So for a general case conference, you should have a surgeon, a pathologist, a radiologist, a radiation oncologist, and a medical oncologist present to discuss the general patients that are presented. Now, there are always a need for non-physician specialists in attendance at conferences, and these, while not limited to, but are appropriate for genetics, clinical research, palliative care, psychosocial issues, rehabilitation, and supportive services. Now, of course, other members could be present from the nursing service or the training institution if there's a complex academic institution involved. But these are generally the people that should be at a cancer conference. Next. The Cancer Conference Coordinator should evaluate and report annually to the Cancer Committee. Now, again, there are specific areas that should be listed in the minutes, and this is very important. The Cancer Conference frequency, the multidisciplinary attendance, the elements of discussion for each case, and an action plan to resolve any issues that have not been followed by the policy and procedure, such as if stage has not been discussed frequently, what are we doing at the institution to increase the staging discussions for our patients? Now, elements of discussion for each case can be included but not limited to the clinical and pathologic stage. Both are important. The treatment planning using evidence-based guidelines such as NCCN guidelines, genetic testing where applicable, clinical research studies, and the eligibility for supportive care. Now, it's important to document all of these very, very carefully in the minutes, and the Cancer Conference Coordinator must discuss these when he or she is discussing the overall cancer conferences with the Cancer Committee.